Hey guys, what's up? Um, so this mini lecture is going to cover anxiety disorders and goes along, coincides with our abnormal psychology text, chapter 5. Yes, this is chapter 5. So here's the thing. Your text has a ton of information on disorders, and I think it's good. And if you plan on continuing in psychology, I actually suggest you hold on to this text because it's got some really good fallback information. I certainly did that throughout my college career. There are a couple textbooks that even through my doctoral program, I still was referencing for information on certain things. That being said, a lot of that information is really, really deep into the statistics and the the prevalences and the treatment options and stuff for certain disorders. And that's all great information, but frankly, for a community college level course, I'm more interested in you understanding what the disorders are. Um, you know, the classification of them, what they are, and how to recognize them first. We can get into how to treat them later, right? I will give a little information on that kind of stuff, but to be honest with you, I'm more interested in you being able to just recognize the disorders as they are. So with that, what we're going to cover in the anxiety disorders is the most commonly diagnosed disorders in the anxiety family. So in the DSM-5, Diagnostics and Statistics Manual 5, all of these psychological disorders are broken up into classifications or families of disorders. So there's some that are considered anxiety, there's some that are considered personality, there's some that are considered depressive, relating to depression, there's some that are considered psychotic, there are some that are considered developmental that may be associated with the genetic, some genetic issues that occurred where chromosomes didn't quite work out for that person the way they do in other people, and so they've created some anomalies in development. So these disorders are all broken up into families. And then within these families are the lists of different disorders. For each disorder, for each psychological diagnosis, there's some criteria that we have. So when the person sits down with a psychologist or a psychiatrist and they go over and ask all these questions, all right, so are you experiencing this? Are you experiencing this? Tell me what's going on. Tell me how you're feeling. Okay, these are symptoms you're describing. And they have a list that says, okay, this symptom, this symptom, this symptom, and this symptom all relate to this disorder. They also relate to this disorder. So we have to be able to now differentiate between the two. Like, how do we know which one we're dealing with? And, I've had to, I've gotten the opportunity to talk with a lot of persons with different psychological disorders over time. And there's some common threads in those conversations. What you hear from people a lot is, oh, I was misdiagnosed at first. Oh, they misdiagnosed me. Maybe. It's not necessarily that you were misdiagnosed. It's that there's a lot of overlap between a lot of these disorders. And it's pretty easy on one day to look at one and say, oh, it looks like that. And then on another day, with just a little bit different mood, to be, it looks like that. So when we're dealing with psychological disorders, with the exception of a few, like schizophrenia and those with really kind of dramatic symptom presentations, what we're really talking about is what category does that symptom pattern fit into the most, okay? Because at the end of the day, if you suffer from or deal with generalized anxiety disorder versus panic disorder, the fact of the matter is the treatments for both are pretty similar, and the cognitive behavioral therapy for both is pretty similar, and the kind of prognosis trajectory is pretty similar. So I'm not saying it doesn't matter which one it is. It does matter, but we, especially as patients, we tend to get to pigeonhole ourselves and say, oh, well, he told me I had generalized anxiety disorder, but this psychologist says I have panic disorder, and that is why I'm not getting any better. And that is probably not true. Um, the truth of the matter is, especially when it comes to things like therapy, the patient has to have a lot of agency in their own healing. And some people have an invested interest in not healing and not getting better. And we'll talk about that when we get into the somatoform disorders, the somatic disorders, hypochondriasis, and those kind of things. And that is not necessarily true. There are some disorders that are just very difficult to treat, and people would love to not have them anymore. And some of them are just very difficult to treat. But let's not get hung up too much on trying to pin down these different separate disorders under the families. I want you to understand the main symptoms of each disorder. Okay. Also, and I'll probably have to give this this little notification at the beginning of every one of the lectures going forward. You know, you may, if you are somebody who deals with one of these disorders, or you are somebody who has dealt with trauma, or you're somebody who knows somebody who deals with one of these disorders, who you care about, you may find some of this information uncomfortable to hear. I'm not going to use the word triggering, because triggering is something specific to post-traumatic stress disorder, and that's something that the media has really, really overused and has gotten into our social consciousness. And as someone who's worked with a lot of people with PTSD, they kind of find it offensive, because a trigger is a very specific thing to somebody with PTSD, but it may be uncomfortable, and it may create some emotional disturbance, which I guess technically would be a trigger, but either way, whatever you want to call it, whether you want to call it a trigger or you just want to call it emotional disturbance, you know, if this is something you need to stop, come back to, or you need to talk to somebody about, the school does have options available to you to talk to people. So with that said, let's jump right in, okay? So anxiety disorders. So there's zero chance you've gotten to this point in your lifetime and you haven't experienced anxiety at some point. And we all know what anxiety is. Anxiety is worry about things that have happened or are going to happen. It's a fear or worry about uncontrollable future events, right? We know what it feels like, right? You get the sweaty palms, your heart races, those kind of things. We've all had anxiety, worry, felt nervous about something, whether you're going in for a big job interview, or you thought you were about to get in trouble at work, or you thought mom or dad caught you sneaking out, or whatever. We've all experienced anxiety before, okay? That is normal. That is a part of your body's fight or flight response, and it is completely, absolutely normal. You got to remember, for any psychological disorder at all, the symptoms have to be pervasive, which means powerful, and they don't go away. And they have to actually interfere with your daily functioning. Okay? Because just like if you go on, maybe you've done this, right? You got a weird symptom. I got a spot on my throat, or my throat hurts, or I got a cough, whatever, and you go on to WebMD. Don't do that. You research it. What do you got? You got cancer. Everybody's got cancer. You go on WebMD. Everybody comes away with WebMD. Oh my God, I've got stage 4, super rare terminal disease, and everything, because the symptom is, you know. And if you do have cancer, my apologies. But you know what I mean. Right? So when you hear this stuff, when we go over this stuff, like, oh my God, I've experienced that symptom before. Oh my God, I've experienced that symptom before. Well, yeah, you have. But unless it is absolutely impeding your ability to function in life, it's not at the disorder level. That is one of the criteria to make it a disorder. All right. If it is impeding your ability to function in life, and we've thrown back the curtain on something, good news is there's help. Go get some. Okay. All right. So the difference between panic and anxiety. Anxiety is a feeling of worry or dread, all right? Panic is supercharged anxiety. It is an intense feeling of fear that is paralyzing, usually paralyzing to the person. Like, they become so afraid or so terrified they cannot move, they cannot function. And it is accompanied by some very measurable physiological reactions: a super accelerated heart rate, the sweating, the clammy skin, all the fight or flight response things, right? They come in. When somebody is experiencing full-blown panic, when somebody panics, when we talk about emergency situations and we're like, oh my God, don't panic. The reason why we tell people not to panic is because when you panic, you become functionless. You can't move, you can't walk, you can't think. Your brain has gone into its animalistic um, uh, rear brain. You've lost your fine motor skills. You cannot do anything. You're just existing in a state of fear. Okay, panic is not a good thing. If you have ever experienced panic in your life, that is because whatever situation was going on exceeded your threshold to deal with it. And the military and law enforcement and fire service and stuff train people by stress inoculation, by exposing them to stressful situations over and over and over again to raise their panic threshold, so that when they do encounter a horrible tragic event or a disaster or something, they don't panic because they've experienced this and seen it before. Novelty is a big part of panic. You're more likely to panic if you encounter a threatening, stressful event that you have never encountered before. You're less likely to if you have encountered it before or something similar before. Again, so that's why the military and the police and firefighters, they train the way they do. Okay, but while it's not a great thing, panic is also normal, so to speak, which is to say it is a normal response to a event that exceeds your threshold to cope. Okay, so both panic and anxiety are normal, but both of them can be disorders if they are pervasive and disrupt your ability to function in life. Make sense? Okay. So just because you panicked at some point in your life or just because you experienced anxiety doesn't mean you have a disorder. However, generalized anxiety disorder, write that down, GAD, generalized anxiety disorder is a constant, pervasive feeling of anxiety that won't go away. And it's not about any specific thing. Somebody who experiences generalized anxiety disorder is constantly, or more often than not anyway, in a state of anxious worry. They feel that physiological anxious worry response. The heart is beating, they're sweating, they're afraid, but there's not necessarily something for them to be afraid of. And if you think about it, that's kind of a crappy way to live, right? This can impede cognitive reasoning. It can impede your ability to think. It can affect your mood. It can affect your ability to do things, to go to work, to play with your kids, to play with your dog, to be a good partner to your significant other. It can affect you in a lot of ways. And um, when somebody with generalized anxiety disorder is confronted with a stressor, that tends to become immediately the focus of their anxiety. So their anxiety is out there existing, and then it's just looking for something, right? It's looking for something to be stressed about. And so it could be the littlest thing. Somebody calls on the phone, and when it's time to stop talking, they say goodbye, but they don't say goodbye in the way they normally say goodbye. They sound a little curt, a little short, and all of a sudden the brain will go, boom. Oh my gosh, they must not like me anymore. They don't love me anymore. I've done something wrong. I've offended them. This is the person who absolutely cannot let it go. They cannot let it go. What is it? Anything. It doesn't matter. They cannot let it go. And again, this goes beyond the worrywart level to the place where it was disruptive to your entire life, to where you cannot function. And GAD, generalized anxiety disorder, is one of the most commonly diagnosed disorders in the United States, next to depression. I had a friend with anxiety, and she described it this way. She said, "Depression is what happens when anxiety finally gets exhausted." So generalized anxiety disorder disrupts your ability to sleep. It disrupts your ability to function. It takes away your ability to enjoy anything in life because you can't truly engage with anything because you're always worried about what's coming, even if you don't know if something's coming or know of a specific thing that's coming. While it is so very common, and we do have plenty of treatments for it, it can be a very painful thing to have to live with. Where does it come from? We talked about nature versus nurture a little while ago. And we talked about things with a biological and things with environmental effects. We believe with the anxiety disorders that there is some biological predisposition something in the person is biologically predispositioned to have it, and then things that occur in their environment activate that, if that makes any sense. So we see people with generalized anxiety disorders. They often grew up in abusive homes, not necessarily like physically abusive or sexually abusive, but perhaps but psychologically abusive, mentally abusive, parents who withheld love and those kind of things. These people grow up with a constant sense of feeling like it's not right, it's not going to be good enough. They're families, when kids grow up in broken homes where there was a heck of a lot of fighting, maybe even domestic violence in the home, sometimes they grow up with generalized anxiety disorder because they've learned to be afraid at all times. Okay, so that's generalized anxiety disorder. Questions? Just kidding, I can't see you. Panic disorder is like having generalized anxiety disorder on steroids. So when a person has panic disorder, those panic attacks or that situation of panic that we talk about occurs to them as an event. So they can be sitting watching TV and all of a sudden this panic will come on them in much the same way a seizure might come on somebody with a seizure disorder. So, and over time, people with panic disorder have told me they can actually feel it coming. They recognize the symptoms. They recognize the change in their thought pattern. They recognize the change in their breathing and how their heart feels and stuff. And they can try and fight it off. They can take their medicine. They can do certain things. But at the end of the day, if they just get hit with it, then it strikes, and the person then becomes immobilized with absolute fight or flight. Overload. And the anxiety from a panic disorder doesn't come in a generalized way like it does in GAD. The day-to-day anxiety is anxiety about having the next panic attack. Okay. If you've ever experienced a true panic attack, and just because you've had a panic attack doesn't mean you have panic disorder. Again, this is something that has to occur on a pervasive basis and disrupt your life. But if you've ever had a panic attack, you know that it's a terrifying and debilitating experience. A lot of people with panic attacks end up in the hospital on EKG machines, believing that they're having a heart attack because they cannot breathe. Their chest muscles tighten up and cramp up, and you lose physical strength. You cannot stand up. It's a terrifying situation. And when people have a panic disorder, they don't know when the next panic attack is coming because it doesn't have to have an external stimulus or trigger, right? You can be absolutely having a great time, family picnic, right? And all of a sudden, boom, it hits. And so they suffer from a type of generalized anxiety disorder about having the next panic attack. With both of these, generalized anxiety disorder and panic disorder, there are treatments, and a lot of them involve the same types of medications that we use to treat depression, stuff I know you've heard of, things like Prozac and Effexor, and those things are out there. And those do offer a certain measure of relief, but we find out that those of course target the biological, the neurotransmitters in the brain. But we find out the best treatment for both of these disorders is kind of a combination of nature and nurture, sort of a talk therapy and cognitive behavioral therapy to teach the person how to recognize the panic coming, how to recognize the anxiety, how to deal with it, what to do when they feel it coming on, and how to live with it while the medication is also doing its thing. So the prognosis for both is actually pretty good. Sometimes panic disorder, generalized anxiety disorder go into remission. Sometimes they're with the person their whole life. Sometimes it comes and goes their entire life. Most people get it to a point where they can function. So it'll be really, really bad at first, and then they'll figure out a way to get it to a functional level so that they're able to go about their life and do certain things. Okay, phobias. So a phobia um, and we talked about this during the first lecture, is an irrational fear or disgust related to a specific thing. And the book goes into a whole list of different phobias, and you feel free to go over those. And some of them are kind of cool and interesting to learn about. We talked about one of the most common phobias out there, arachnophobia. Um, but if you know somebody or are somebody who experiences just an irrational, absolute revulsion and fear, a panic disorder, really, over a specific stimulus, that could be a phobia. Now, when I say irrational, it it can't be I'm afraid of having a gun pointed at me. That makes me afraid when I have a gun pointed at me. It is perfectly rational to feel fear when somebody points a gun at you. Um, you know, it is it is rational to feel fear in frightening situations. It is not rational to be so afraid of going into an airplane that you cannot visit your family, um, when they've paid for the tickets and you haven't seen them in forever and you love them and you miss them so much. And we talk about it being irrational and affecting your life when the phobia keeps you from doing the things you want to do. Um, you know, I've known people who were so afraid of being in an elevated position they couldn't get on a step stool to grab something on top of the refrigerator. Um, you know, so those are types of phobias that are definitely impeding this person's life. The book says that the vast majority of phobias are nature, or excuse me, nurture related, which is to say they're environmental, and that is the case. Most phobias are a result of a learned experience from a trauma or something that happened. So somebody, when they were a child, got locked in an elevator for hours and hours, and now they have claustrophobia. They every time they're in a closed space, they start to have a panic attack. Um, Perhaps they, um, when they were a kid, there was a very vicious barking dog that snapped at them and even perhaps even threatened them, or they perceived that it was threatening them, and that child thought they were going to die, and that stressor was bad enough that now they've developed an actual phobia of dogs, and every time they get around a dog, they start to have a panic attack. Um, and it's funny, the book addresses this in the first chapter, but doesn't address it in the section on phobias. There's also the potential genetic, um, evolutionary idea that certain phobias, like the fear of snakes and the fear of spiders, could be genetically programmed right into us. Also, tryptophobia, the fear, and go with me on this, because if you've never heard of this, some of you are going to know exactly what it is when I explain it. The fear of the honeycomb or multiple little holes. Um, and when they see this pattern on somebody's skin, like imagine if somebody touched a honeycomb or a tennis racket and pressed it really hard, and they left the little holes in their skin, or they had a bunch of tiny little holes there, or the honeycomb shape, that really freaks people out. Seriously, yeah, I don't like it. When I see it, I'm like, ugh. and and there's some argument that the genetic basis for that is that pattern occurs a lot in life in very dangerous plants, dangerous situations, wasp hives and those kind of things, and that could also be genetically pre-programmed into us. So for the most part, yes, phobias are a result of experience over biology. There is some argument that certain phobias are biologically have a biological imperative to them. Either way, the treatment for phobias is pretty much the same across the board. It involves it involves repeated exposure therapy, exposing the person to the thing that they're afraid of over and over and over and over again. Remember how I talked about how we stress inoculate law enforcement and soldiers and firefighters and EMTs against having panic attacks. We do the same thing with people who have phobias. We try and stress inoculate them. So you're afraid of spiders, so we show you images of spiders. We show you images of spiders, and then later on maybe we show you live spiders. We take you somewhere where there's actual spiders in glasses, and then maybe it finally culminates in you letting a spider crawl up your arm. And if right now you're sitting in your chair watching this, going, "Heck no," and you feel like the sweat on your moms and stuff, well, then you understand how challenging those types of treatments can be. Most phobias are never cured because most people don't have a good reason to put themselves through that type of torture. You know, um, I'll give you an example from my personal life, though, and it sucks. My my kids' grandparents, my parents, my dad had a fear of flying. And when we moved to the islands, I desperately wanted to show them where we were living now. I wanted them to see my kids again. And they missed my kids so much. My kids missed them. They loved each other so much, but my dad could not get on the dang plane. And that got in his way. And unfortunately, he never got to see their home here. He never got to come here and see that. And so a phobia can reduce your quality of life. But unfortunately, it's just not one of those things that people seek a lot of treatment for because they don't want to let the spider crawl up their arm. Okay, make sense? All right. And phobias, by the way, they can make some sense when you hear them, right? Fear of heights. Okay, I get that. You fall, you die, right? And then sometimes they can be so unique and specific to that person's experiences that they almost sound weird, like a fear of pillows or something. But you don't know what happened to that person that caused that. All right. PTSD, post-traumatic stress disorder. This has got to be one of the most misunderstood disorders out there, and that has almost everything to do with Hollywood. So post-traumatic stress disorder is actually, diagnosis-wise, pretty freaking simple. The person experiences a life-threatening event. That event does not necessarily have to be truly life-threatening. They have to perceive it as life-threatening. So in reality, maybe it wasn't life-threatening, but they thought it was. Okay. Maybe someone pointing a gun at them, maybe the gun was actually an airsoft gun or a BB gun or a replica, so they weren't really in danger of being killed, but they didn't know that. They thought they were. Okay. They experience a life-threatening event. And the definition has been expanded, a loved one or someone you care about strongly experiences a life-threatening event. Okay? Or you are exposed to intensely traumatic events on a repeated basis. Okay? The definition has been expanded to include all sorts of what we call the criterion A, or the initial stressor. Okay. Traditionally, the initial stressor is you're exposed to a life-threatening event. They expanded it. You or someone you're very close to is exposed to a life-threatening event. They expanded it again. Okay, you are exposed to a life-threatening event. Someone you're close to is exposed to a life-threatening event. Or you're exposed to a whole lot of not quite life-threatening, but really bad stuff for an extended period of time. So that's the criterion A. That's the first part. That happens. The next part that happens is you have this package of symptoms that comes along with it. The most common of the symptoms is the avoidance symptoms. The person will, at that point, do everything they can to avoid reminders of that event. And when I say PTSD, people most commonly think about soldiers returning from combat. And there's a good reason for that. They've been the most studied, and they are the easiest to study. We have whole swaths of our population who, and I mean humans, who we've sent to combat and are come back with post-traumatic stress disorder, and they're right there, and we can study them as they're coming up. So there's this kind of link with the military and PTSD, but PTSD is far more common than that. It's not just soldiers in combat. It is women who have, or men who have experienced a sexual assault. It is kids who have lived through highly abusive parenting. It is regular citizens who've been involved in terrible car accidents. It is law enforcement officers detectives who have never actually been shot at or had something like that, but have had to see dead body after dead body after dead body for 15 years. It is firefighters who have had to do CPR on infants. It is, it is regular citizens who've been involved in combat situations where they have been forced to defend their lives against a life-threatening assault. It is, again, police officers who've been involved in gunfights. It goes on. The list goes on and on and on. Anything you can think of that could be life-threatening or heavily traumatic applies. So yes, it is easily studyable when our men and women come back home from the military, but the military is by far not the only population with this, and in fact they're not even the biggest population with it. They're just the one we've studied the most. Okay. Post-traumatic stress disorder, once the stressor has occurred, then the patient will begin to engage in avoidance behavior. They will avoid reminders of the event. That can be as simple as let's use the military example, avoiding fireworks, right? Because the sound of the concussive blast in the air may remind them of combat. It can be, in the case of some law enforcement officers I've talked to, avoiding grisly horror movie shows, because seeing chopped up dead bodies that other people think is fun, Halloween fun, for this person may remind them of every crime scene that they've had to be on. I talked to one detective. He could not be around baby dolls, like little girls, little anybody's dolls. Couldn't be around dolls because they reminded him of dead children, right, that he had to see. So there becomes that avoidance, and that avoidance can become, that part alone can become debilitating, right? Because all of a sudden now you are not taking part in things that, as a wife, as a husband, as a father, as a friend, as a member of society, you may be socially expected to do, right? To be considered good at that role. Now you can't do them anymore, right? You cannot go out and go to the mall, because that type of large crowd and the noise of the crowd is too reminiscent of certain events that have occurred to you, for instance. So there's the avoiding reminders, the avoidance. Then there's the reliving aspect. And this is the part that Hollywood loves to mess with, right? The flashbacks, right? Because whenever this happens on the news and we find out somebody has committed a violent crime and they were in the military, the news automatically starts asking, well, maybe they had PTSD, maybe they're in a flashback. Okay. Bullcrap. So the reliving part is an unwilling, undesired, unasked for re-experiencing of certain parts of the event. It can be strictly emotional, where the person goes right back into that feeling of panic, fight or flight that they had at the time of the event, if they did in fact panic. It can be dissociative, where, and we'll talk about that a little bit later, where they actually, for the rest of the world out here, they look like they've gone into a trance, but in their mind has taken them back to the event and they're reliving it in their mind. Or it can be an actual delusional flashback where they experience the events as they occurred. Have there been cases where somebody was experiencing an actual fully immersive flashback and they've acted out violently without intent to somebody? Yes, that has absolutely happened. That is the least common thing that somebody with PTSD does. The majority of people with PTSD, when those triggers activate, when they are unable to avoid the reminiscence and they become triggered and the reliving occurs, the majority of people, you'll find what they do is they either go catatonic or they cry and shake and are terribly, terribly afraid. They can also manifest in anger. It can manifest in in unpredictable explosive behavior. But the most common response is a fear response akin to a panic attack. That reliving can also occur in nightmares. And very often people with PTSD are plagued with nightmares of the event that disrupt their sleep and keep them from getting good night's sleep ever. And it's constant, it's pervasive, and and it can be very, very destructive to their physical health as well as their mental health. And the triggers that cause these things to occur don't have to be as obvious as you might think. I talked to somebody was triggered by blue milk cartons because of something he had experienced, a terrible, violent thing that he had experienced that isn't the subject of this conversation, but he experienced a terrible, violent, traumatic event, and blue milk cartons featured strongly in it. And because of that, anytime he saw those, felt them, touched them, his heart would start to race. He'd start to feel panic. His mouth would go dry, and he didn't even understand why it was happening. Because at that time he was a beer delivery person, so he had to carry stuff in the cartons all the time, right, to go into the bars and go into the stores, and he couldn't understand why it was happening, and they had to break it down and go back and figure out what the heck was happening for him. So the triggers don't have to be something as obvious as fireworks, right, for gunfire, or something big and obvious. They can be very, very subtle. Once a person with PTSD identifies those triggers, they will very often take as much care to avoid those triggers as they can. And this is where we come to the debilitating part of their life, right? Because if the trigger is just something as innocuous as a blue milk carton or a blue milk crate, you're going to be spending a lot of time avoiding a lot of places, right? If your trigger is the smell of diesel fuel, that was another one I dealt with. I mean, imagine going outside and not being able to smell diesel fuel without having a panic attack, right? That's going to affect your life, and it's going to affect it rough. The treatments for post-traumatic stress disorder. Where does PTSD come from? Let me explain that to you. It is not, I just want to get this out of the way. One of the most ignorant things I ever heard anybody say to me was that they just need to get over it. They just need to get over it. If they could get over it, they wouldn't have PTSD. The problem with PTSD is your brain won't let you get over it. Very often the person is trying to move on, they're trying to move forward in the future, but the brain keeps locking them into this event in the past. And I had somebody explain to me once that PTSD steals your future, it steals your present, it traps you in the past. It will not let you out of that event. It does happen on continuums, on scales. Some people's PTSD can be comparatively minor to other people's PTSD, which can be absolutely debilitative and require full-time hospitalization. Some people's PTSD resolves in a matter of a few months. Some people deal with it their whole life. For many people, it goes into remission and they're able to live perfectly normal, happy lives. My father was a Vietnam veteran. He had PTSD when he came back, and only very rarely were there times where he saw something that after that that would cause some type of triggering effect. If you're watching a particularly violent war movie like We Were Soldiers or something like that, but for the most part, it wasn't an issue. And that's not the case for everyone. Not everybody's prognosis is the same. I'm just saying it's not the same for everybody. How does it happen? It goes like this. You have a built-in biological threshold, a stress threshold. Okay. For some people it's up here, for some people it's down here. It's your resiliency threshold. And then this trauma occurs. And if that trauma exceeds that threshold, that activates the post-traumatic stress disorder. People with PTSD have actual brain changes that occur in their brains that show that their thought processes work different than people without PTSD, which is to say this is an actual brain injury. Okay. Now, what that means is that it can be very difficult to treat. It can be treated. There are medications out there that help. There's medications that help with the nightmares. There's medications that can help with anxiety, the same type of anxiety medications that give other people. Sometimes if the person is really intensely experiencing it, they'll use even antipsychotics to help with things like flashbacks and stuff. And sometimes people with PTSD only need to talk about it. It really depends on the case-by-case basis. PTSD is a normal reaction to an abnormal situation. It is what happens when a human is forced to see or do or experience inhuman things, and they were not inoculated to it beforehand. And there is some argument as to, can you inoculate somebody to the point where they won't get PTSD? I mean, will it eventually occur given enough exposure? Maybe. Maybe not. We're experimenting. My own research into law enforcement and PTSD was about, is there a way to train people to raise that biological threshold? So that's post-traumatic stress disorder. It's a very misunderstood disorder out there, and we do a lot of discredit to veterans and sexual assault survivors and police officers and people who have it by categorizing them all as these Hollywood psychotic killers, because it's just not fair. That's not the case at all. Like with any mental disorder or any disorder, you know, there's always going to be anomalies on the side that have done horrible, tragic, terrible things. But, you know, for the most part, these are people that want to just live their lives like everybody else. Okay, obsessive compulsive disorder. This one also goes on my list of highly, incredibly misunderstood disorders. So you know somebody, you've got somebody in your life, or you have said this before. Have said, oh yeah, that's my OCD, right? Because I like my stuff clean. That's my OCD. I keep all my stuff straight, or all my books, because that's my OCD. Chances are you don't have OCD. And the reason I know you probably don't have OCD is because you're functioning. Okay, and people forget that critical part of the disorder thing interferes with your ability to function in life. Obsessive compulsive disorder does not mean you're clean. It does not mean you straighten pictures. It does not mean that you like things done a certain way. That's being type A. Okay, that's being anal retentive. Obsessive compulsive disorder is literally best explained by breaking the words apart. Obsessive means there's a thought, an obsession. There's something in the person's head that they cannot stop thinking about. And it's generally terrible. It's awful. It's the murder of a child. It's the, it's the death of a loved one. It's something bad. It's an obsession. It's a fear. It's I'm going to lose my job, like the generalized anxiety disorder, right? It can be specific, like the death of a family member. It can be non-specific, like just this intense generalized anxiety. That's the obsession. Will not go away. It's an intrusive thought. They would like it to stop. They cannot make it stop. The compulsion is the behavior. The compulsion is what they do physically to make the obsession shut up. So a person with obsessive compulsive disorder has an obsession, and there's a compulsion associated with it that relieves the symptoms of the obsession. That compulsion is generally ritualistic, and it involves doing something extreme. Maybe washing your hands 300 times a day. You may have to flip the light switch on and off 13 times before you leave the house every time. These are just some I've come across. Somebody with obsessive compulsive disorder engages in these ritualistic behaviors. A lot of times there's collecting involved in it. People will compulsively collect certain objects, salt shakers, things that may not make sense, and they don't have to make sense. And they don't have to be directly tied to the obsession. They don't have to have anything to do with it. The person's compulsion can be to collect brunette Barbie dolls, and their obsession can be about losing their job at work. Right? And they literally put themselves into bankruptcy buying every brunette Barbie doll they can come across because that's the only thing that relieves the obsession. The most common compulsions are things like hand washing, or obsession, or with cleanliness. The obsession will have something to do with germs, diseases, and things infecting their body. And so the compulsion will be to clean their hands or clean something every time they see it. That's where that whole kind of I'm clean, so I have OCD thing comes from. The disorder part is they do this to the point where they cannot live their life in a normal, healthy way. Okay? They've got an obsession. It's a thought that won't go away. A compulsion, an act that they have to engage in to relieve the thought. And they do that so much that it makes it into a disorder. You can have OCD technically and have a perfectly functional life. If somebody has to flip the light switch on 13 times before they come in and out every single time, they're probably able to hold down a job, right? But if your compulsion is something that is not socially acceptable, like something sexual or stealing or something bad, then that can be a recipe for personal disaster. Because this obsession is so strong, it's such a painful, horrible, terrible thought that they'll end up in a full-blown panic if they don't relieve it with a compulsion. So it can be an incredibly debilitating disease. It can also be a disease that isn't quite so bad. OCD has been presented several times in several movies and TV shows, and it's almost always brought up in a comedy sense. And I'm a big one for laughing at everything. I don't get offended by stuff, and I do think people get offended by way too much stuff way too easy. But we do have a tendency to never present it with the gravity that it is. This is a disease that can really affect somebody's entire life, and it certainly has nothing to do with just wanting your house to be clean. So anyway, those are the anxiety disorders that we're going to go over today. I hope you guys found this interesting. I hope you got something out of it, and I will talk to you guys soon. Thanks.